this session. I hope it's fine with all of you. I welcome you all on behalf of the CSMCH-Alumni Association, and I'm both humbled and extend a warm, heartfelt welcome to each of you, our chair, Professor Sheila Zurbrigg, speaker, C. Sathyamala, CSMCH faculty, staff, students, alumni, and friends to the People's Health Oration 2025. It's great to connect with friends who make up the fabric of our public health community in India and across the globe. We celebrated the Center's 50-year celebration in 2023-24 and initiated two important events, the formation of Alumni Association and the People's Health Oration. CSMCH Alumni Association, along with the Center, is organizing People's Health Oration annually, which brings the promise to be inspiring, fulfilling, and impactful as the first in 2024. It has been a hard work of 2 decades of bringing together the CSMCH alumni and forming the association. In 2018, the CSMCH alumni meet was formally organized, bringing in the generations of CSMCH. The center completed 50 years of its existence in 2021 during the COVID-19 pandemic. The center's faculty, students, and alumni over the year 2023-24 celebrated these 50 years of the center and its work in the domain of public health. In 2023, CSMCH alumni collectively decided to form the Alumni Association with an interim EC serving for the 18 months. The second CSMCH EC was selected in July 2025 through an online GBM, and it's functioning now through its various working groups. Before I hand over to Professor Rajiv Dasgupta, I'd like to share some of the house rules. The Zoom chat will be closed during the oration, and the Zoom chat will be opened after the vote of thanks for questions or any kind of comments to be shared with our speaker. And after Professor Dasgupta's sharing, there will be chairperson's remark, oration, and chairperson's concluding remark, which will be followed by vote of thanks by Professor Ramila Bisht. With this, I request Professor Rajiv Dasgupta, Chairperson, Center of Social Medicine and Community Health, to share the history of the center and TPHO. Thank you. Over to you, Professor Dasgupta.
Hello. Good afternoon. I hope I'm audible. I am joining from, I am on fieldwork in Rajasthan. So it's an absolute honor to welcome you all on behalf of the Center of Social Medicine and Community Health to this People's Health Oration being delivered by Dr. C. Sathyamala with Dr. Sheila Zurbrigg as the chair. And many congratulations to the Alumni Association for organizing and coordinating this. I also take this opportunity to welcome many friends and colleagues of the center across generations. And as a brief recap and context, the Center of Social Medicine and Community Health was set up on April 13th, 1971, when an incredible experiment, if I may, started with three very distinguished doyens led by Professor D. Banerjee, Professor Imrana Kadir, and Professor Ramalinga Swami. And it is on the foundations laid by them that we completed 50 years, which coincided with COVID, but that has actually led to a strengthening of our resolve in shaping the vision that they had set out with. And as Dr. Vijay Rai said, we had the Foundation Day celebration and followed by a webinar series, again delivered by several distinguished colleagues and friends. And now this annual People's Health Oration has been instituted with the support primarily from the Alumni Association. And I really congratulate all members, the previous body and the current body for taking this forward. On a personal note, Dr. Sathyamala, this is a very special occasion to welcome you. I don't really need to welcome you in that sense, but my very first publication in this center after joining as a faculty was with Sathyamala, she leading the paper. It's absolutely wonderful to have you back. Thank you very much, and over to Chair Professor Sheila Zurbrigg.
Yes, it's thrilling for me to be here. I have to say, I'm quite overwhelmed. But let me try to gather my thoughts through these emotions. I want to thank Dr. Roy for helping organize this and for your introduction, and to all who sit on the organizing working group for this event. I feel very honored and pleased to be asked to chair the second annual CSMCH People's Health Oration. I met Dr. Sathyamala very briefly during my years working in Ramnad district, Tamil Nadu, at an NIN conference in the late 1970s. That meeting alerted me to her broader critical analysis of nutrition issues in the country. Her writing, along with others within the MFC Bulletin group, was invaluable encouragement for me in my pursuit of understanding and the underlying root causes of preventable mortality that we were seeing in Ramnad. And beyond responding to, in effect, Mina's emphatic diagnosis later on regarding a preventable mortality, there being no time, no paisa, nerum illai, paisa illai. Those 4 words kept ringing in my mind and heart, and still do. Satya reminds me that we also met in 1985 in New Delhi, both of us marveling at the timing of the 2 books, Raku's Story and Taking Sides, appearing virtually together and complementing each other in many ways. But today, let me confess to being more than a little daunted by the invitation. Let me just get my spectacles. Daunted by the invitation to chair this event. Daunted by the sheer extent of subjects that Satya has taken on in her 4+ decades of health analysis in the country. But daunted also, given my absorption in historical South Asian health and hunger research over the past decades, historical work that took me down quintessential rabbit holes that pulled me away almost completely from contemporary public health issues. Despite these misgivings on my part, I realized the personal opportunity, the invitation, your invitation offered for re-engaging, even at a minuscule level, in the country's current food security issues and people's health movement. So here I am. The range of Dr. Sathyamala's writing is immense. From her incisive critique of healthcare inaccessibility for the rural and urban poor in Taking Sides, to her continued advocacy for the victims of the Bhopal catastrophe. Her critique of the risks of injectable contraceptives for women, HIV/AIDS treatment advocacy, more recently, critical analysis of the Pulse Polio campaign, to mention only a few crucial issues. All this while taking time to publicly support MFC colleagues such as Binayak in his efforts to extend healthcare to spheres of economic justice in Chhattisgarh. Much of Sathya's work, of course, has been undertaken alongside political critique within the growing MFC collective, and of course, the research and training work of the Center for Social Medicine and Community Health. It is Sathya's unremitting critique of the reductive trajectory of nutritional science, however, that has been of particular compelling interest for me. And here I refer to the post-World War I shift in academic attention from quantitative macronutrient deficiency, i.e. hunger, to instead micronutrient deficiencies, a supplanting of the former quantitative issues by the latter. This narrowed trajectory, traceable to Edwin Chadwick's earlier selective focus on external miasmas, environmental filth, in his 1840 sanitary report, which conditions of the human host, starvation, physical exploitation among industrial workers was expressly excluded from consideration. The ongoing effect of this exclusion of the human host in 20th century epidemic and public health analysis has had profound effects, of course, and in South Asia as well. Especially in South Asia, despite hunger remaining pervasive, even into the 1980s and certainly beyond in areas. A reality reflected in the continuing colloquial Tamil greeting, Saptacha, or should I say it, Saptacha? Have you eaten? Which was a constant reminder for me in those days of the importance of hunger. Yet, in spite of this common understanding, to this day, the epistemic narrowing of public health has meant micronutrient campaigns continue to be pushed by Western corporate interests. And here I include from Canada support. And I'm embarrassed to have to say that. This unfortunate reductionism and focus on micronutrients has been assiduously traced by Sathya. And here I refer to the global nutrition reports that she has continues to critique. The Saptacha question and the constraints it presents for health and for access to basic health care has informed much of Sathya's work, extending from the national level down to state, then district and village levels, and ultimately in her PhD dissertation to that of the household cooking pot, through detailed observation in the Triniveli village of Oro, the name that she gave to the village that she worked in for the year and a half. Observations on how much individual household members actually ate meal by meal over the course of an agricultural year. This is an amazing study. These few words obviously don't begin to do justice to the range of Sathya's work. So I'm greatly looking forward to hearing much more about these decades of her work to challenge the narrow domain of public health and to help reclaim the people's health.
Thank you, Professor Sheila Zurbrigg, for this detailed note on Satya's work. I think I'm sitting among, it's very daunting and it's at the same time privilege to sit among these stalwart figures. I hope the audience can excuse me. I will once again introduce Professor Sheila Zurbrigg, who is a Canadian physician with master's degree in public health, followed by in 1974-75, working with the WHO smallpox eradication program in Uttar Pradesh. She helped to develop a primary healthcare program in rural Tamil Nadu, working with the traditional village midwives of Ramanar district, based from the government hospital in Madurai. Returning to Canada in 1980, she sought to document the village dies insights into the continuing barriers to child survival, food precarity, economic disparity, and conditions of women's work. These insights informed her first book, Raku's Story, Structures of Ill Health and Source of Change, published in Bangalore in 1984. She came to explore, in turn, the historical role of hunger in malaria mortality in colonial South Asia, and more broadly, the centrality of staple food security in the overall rise in human life expectancy. She was funded by the Social Sciences and Humanities Research Council of Canada as private scholar. Between 1993-2013, she taught at Dalhousie University, Halifax, Nova Scotia, in the Department of History and International Development Studies. Her most recent historical monograph investigates how one's commonplace understanding of the impact of hunger on infective disease lethality came to be lost epistemologically in Western medical and nutritional science and thought. And I would like to say at the center, we all as students started with reading your work on Raku's Story. And much later in our work, in the Jiva study of indigenous dyes in India, we revisited once again Beena, the village midwife in Raku's Story, but under a very different context. And personally, it was a great honor in 2001 to receive the Sheila Zurbrigg Fellowship by CSMCH, which helped me to complete my MPhil dissertation. Thank you, Professor Zurbrigg, once again for joining with us in this oration. I now introduce C. Sathyamala, but I think Sheila Zurbrigg has already told us a lot, but yet I would like to add few words here. In the various forms in academia, we find it's a place of knowledge production where people from different locations have taken space and engage at the intersection of teaching, activism, and transformative praxis, making knowledge more accessible. Over the years, in my interaction and reading Sathyamala's work, I find it is beyond the binary of theory and practice, which is shaped by the everyday life realities and ethical relations with communities and reciprocally. It was in 2004-5, I had the opportunity to meet Sathyamala first at the center, which is located within the School of Science, Social Sciences, and she was providing us a course on epidemiology. Because I mention here School of Social Sciences, I see her long journey from being a public health physician, epidemiology, into the realm of social science, with a PhD in development studies. Currently, she is a visiting senior fellow at the Institute for Human Development in New Delhi and the International Institute of Social Studies in The Hague. Her interests and writings encompass food politics, political economy of health, reproductive rights, environmental justice, and medical ethics. Her writings have been a resource for generations of activists and scholars in India and elsewhere. She is presently the co-principal investigator for the project Digitalizing Food Assistance, Political Economy, Governance, and Food Security across Global North and South. She has been a long member of the Medico Friends Circle, and currently she is the member of the Medico Friends Circle Bulletin Editorial Committee. She was also member of the Advisory Committee on Bhopal, set up by the Supreme Court of India in 2004. She continues to work with the belief that epidemiology can be a powerful tool in strengthening people's struggles. Welcome to you once again. Her oration is titled Living in Life, 4 Decades of Scholar Activism in Health. Over to you.
Thank you, Vijoya, and thank you, Professor Zurbrigg. I'm actually so overwhelmed, and it's been such an honor to be invited as the second oration. I think it's truly a big honor. I also wanted to say that when I received this mail from the center, I wrote a personal mail to Professor Ritu Priya, saying, I feel I have not done anything much at all. And because I think all my work does not seem to have led to any fruition. It has sort of been there, but it has not really gone to the last mile where it should reach the people. So I was in that kind of a very depressive mood because of what is happening in Gaza. Because sitting in Europe, every day there's something or the other that is, reminding you of the cruelty that is being, unleashed on innocent people. Then I thought, okay, if whatever I have done in my life is going to be of any use or help to, others who may be, struggling to find a path, then I would be happy to share my life. So thank you very much for this honor. And I felt, Professor Sheila Zurbrigg chairing this session was a double honor because I have, although we only met twice, in all these years, I have been following Sheila's work and on food, starvation, and infectious diseases. And she's not only a scholar of high repute, but what I value is whose work shows a very rare, compassion. I'm a bit of a racist the other way around. I always find, white people talking about, black people or brown people a little problematic. But there are a few who are, like honorary Indians, and I would consider you as one of those people for all the work and all the contribution you have made to our country and to others. And Sheila's book, of course, Rako's Story, I read it again now to make my presentation, and it's like, fine wine. It is sort of actually improved with age. And it's one book that has sensitized a whole generation of professionals, particularly medical professionals, who are quite difficult to sensitize once they finish their complete their profession. So thank you very much. Starting with my own presentation, I think I should share the, yeah.
Yeah, you can share it.
Yeah, is it done?
No, yeah, now it is done. Yeah.
Okay, do I have to do anything else? No.
No.
Okay. I'm a bit, technologically challenged, so I think, the technology also knows that I have a problem with it. So it also always acts up. Okay, so I titled my talk as Living My Life. It just came into my head. And actually, the title comes from Emma Goldman's autobiography, which is, Emma Goldman was an American anarchist. I don't consider myself an anarchist, but, I was very impressed. I read this book about, I think, at least 30, 35 years ago. So what I'm going to do is not very autobiographical. I'm not going to be drawing any blood, or, I'm not going to be, what I plan to do is, it's like I'm sitting here looking at the kind of work, I and other colleagues have done, and looking at some of the insights and see whether, and so it's like a comment on my own work. It's not going down. Yeah. So I would start with a preamble, some of my major works activities, and I thought I've chosen about the four issues which I would like to analyze and look at some of the insights. One is that, Where There's No Doctor, the book which I adapted, and Taking Sides, which is original contribution. The second is, of course, the Bhopal gas disaster, which I have been involved with from the third month of the disaster, and I'm still involved with the whatever activities are happening. The injectable contraceptives, again, it was right from the beginning when the issue was taken up by us, and I'm still involved with that. And the global polio eradication, which is a very short-lived kind of critique that we made, barely 1 or 2 years. And so I would like to compare these three issues that I've been worked with to look at what was the results, the consequences, or the outcome, and how do we conclude? How do I conclude after that? So the major works is basically adapting where there's no doctor. The first drug campaign was coordinated by me, which was against the use of EP drugs. I was involved with the sex determination and sex selection technologies campaign against it. In fact, strangely, that the first, the pamphlet of this came to our hands in Vihai because somebody had been traveling to Amritsar. And from that, the entire campaign started, co-authoring Taking Sides, which was updated, I think it was actually 1996, into Hindi, translated into Hindi. Then from 1985 onwards till now, it's interventions, the Bhopal gas disaster case. 1985 onwards, it's campaign against hazardous contraceptives, both NETN and DMPA, and also Norplan, but Norplan never took on in India. In 1986 to 1987, very briefly, I was involved in the health project of the Satins program, which was very important at that time, and it taught us a lesson that you cannot hope to enter a government program and try to support it, because that's what we tried to do. And from 2000 onwards, I've been a founder member of Jan Swasthya Sahyog Ganyari, which now runs a hospital and a community health program in Bilaspur district of Chhattisgarh, and 2005 to 207, creating Global Polio Eradication Initiative. And after that, I went to do my PhD, and I shifted from natural science I decided to do the PhD in social sciences, but I'm not going to talk about it. And that was the whole PhD was on food, because that would be completely a different thing. So this is the thing. So these were some of the books that actually influenced me when I was trying to looking out for a thing. My background I don't have a very remarkable childhood or anything like that. And coming from a low middle class background, my parents really dreamed big, and they never discriminated against the son or the daughter. So we all went to professional colleges, and they literally sacrificed their life to put us through the professional college. But I think the first definitive turn came in for me in medical college, where I was one of the people who led a strike And it was the one and the only strike in the medical college. And because of that, all of us were punished seriously and severely, as only a medical college or professional college could do. And amazingly, none of us thought of any self-harm. But what happened to me was, I think it was at that point that I lost all awe of authority and all respect for authority. So that's why I can, today for me, whether you're part of a WHO or UNICEF, it doesn't make any, so there was a set of circumstances which led me to leave post-graduation and go and, work in a rural hospital. It was a more romantic idea of working in a village. I had this vision of, there's this doctor who's come to serve the people, and all the people say wah wah wah, that kind of a thing. But within 2 months, one understood that it is the stark poverty of what people were going through. I went through a very deep, disturbed period of 6 months, and it was during that time I came across all these readings, which I think is of quite interesting. One is the Deschooling Society, Ivan Illich's Medical Nemesis, Pedagogy of the Oppressed, which was Jesuit priest working in Latin America, uh, the Fanshin, which was part of the Chinese Revolution, but subsequently only later one came to know the Chinese Revolution actually caused millions of death, whereas the Fanshin is a romanticized version of what happened in the Chinese version. The Wretched of the Earth by Frantz Fanon. I don't think I really understood the book the way I understand it now, because I teach it in my course on social theory. And here it was more appealing because he was a medical professional and a psychiatrist, and working during the Algerian War of Independence. And of course, this is the Grapes of Wrath, which is a novel, but which is again a very touching kind of a thing. And more, more in the later 70s was the Political Economy of Health. These were some of the books that really influenced me. And there were two people who, I also want to add as I go along the slide to just mention those who have been very important for me in my journey. And it doesn't mean there have not have been others, but these were very, so Kabir Jayatita Rao was the one who actually got me out of the medical college, and I think Mohan Rao knows him very well. And the other one is the Father Sebastian Kaplan. He was a Jesuit priest whose PhD thesis was on theology and Marxism, and he was something a bit of a maverick who would say mass over not wine and bread, but over masala dosa and coffee. So that was his Indianization of the. It was during the 1970s when there was the Vatican, liberalization of the Vatican roots. So these were some of the earlier influence. So what happened was that one of the first activity when I was going through this thing of what to do, I was offered this book where there's no doctor to adapt for Indian condition. So this was this is the cover of the. It was published in Spanish in 1973, then translated into English in 1977, and the Indian adaptation was 1980. And then now it's been translated into 8 major Indian languages, and I think more than 80 languages world over. It was originally written for rural, isolated contexts where there was literally no access to modern system of medicine. A Ferrerian vision of community health text, a Kuhnian paradigm shift. Because actually what happened was that there's this PhD student called Lillian Walkover. She was doing a PhD on where this doctor had traveled through this 40 years. And this was one of the interviews she interviewed me, and I felt that the publication of Where There's No Doctor actually came as a Kuhnian paradigm shift, because till then all the books for rural health workers were always pretty boring. But here it was a beautifully illustrated and so compassionately written, and also very simply written. But as one of my friends said, it was just a technical tool. So all these quotes have been taken from Lillian Walkover. And the people who helped during this time of adaptation was Radha Holla and Agustin Villet from Bihai, Meera Sadgopal. Meera Sadgopal was one of those people who gave feedback, and she was the one who introduced me to Imrana Kadir when the center was in the, near the this ring road. And then the medical friends circle. So this particular period was very important for me. So, but adapting where there's no doctor, what are the problems with it? Because since it was only a technical tool, there's a tension between providing individual medical care versus changing the social, political, and economic conditions that create health and illness. And the book actually lacks a power analysis of the social structures in society, specifically how these social structures affect health. All these quotes have been taken from the PhD thesis of Lillian Walkover. So I given a credit for that. So because of that, because there was so little politics in it, that the contents were acceptable and adaptable. So that's why it could travel all over, apart from the fact that it had no copyrights. But it was at that time, as a breath of fresh air came Raku's story, which questioned, the structures of ill health, which questions, where can, just being, writing a tool book of what to do when there's no doctor, is that sufficient? And these are quotes from your book, Professor Zurbrigg. By looking at people not by means of stethoscope, but, sorry, oh God, uh, but at where and how they live, that becomes the most important thing. So this tension between the individual and the community, the larger socioeconomic thing. So ill health is inextricably linked to the entire socioeconomic system. And in seeking a solution to ill health, this broader relationship must be addressed. That is the link between Raku's mud hut and the laboring existence and the entire structure of society in which it is located. To me, it was such an important book, because till then the books we were using in our training were always by people like Maurice King or David Morley, who were expats who had worked in Africa, and so their lens was, as from a white colonizer's eyes of how to develop or how to change the behavior of the rural masses from the third world countries. So suddenly you have a book which is actually questioning the structures. So it was, and as Professor Zurbrigg said, that it was just coincidental, as she published a book in 1984, and we were actually completing our manuscript in 1984 without knowing that we were doing this thing together. I mean, parallelly, because so that was the 1970s, 1980s kind of them. Something must have happened there, some magic, that these two books came together, and as you said, that they complement each other, and they both were adjudged as among the top 10 books on community health by some in an international journal. So in our book, Taking Sides, the title was absolutely political. I mean, there's no mincing of words there. And we said healthcare work is not neutral. You have to take sides. So we did not ask the question what to do when there is no doctor, but why don't doctor work in rural areas? Which is a very completely a different question. So this is not to negate what David Werner had written, but to take it in the context of what happens and why people don't. Why do they need a technical tool in order to survive? So these were some of the questions we asked. I mean, so it was also Raku's story was a case study of a woman, Dalit woman in a village. Here it was a health worker, and health worker, we used the word, a very broad definition of it, which could be not just a village health worker, it could be a nurse and even a doctor or any professional who wanted to do health work. So the question was, are people so poor that they do not even have milk for tea? Then the next question of why should a health worker be interested in knowing how poor a person is? And following question is, why do some of us have so much while others have so little? And the answer to that was there was exploitation. So we asked the question, and exploitation is the cause of poverty. Why do people let it continue? So these are all from the first section. There's 4 sections. So later, when I started doing my PhD in social science, I learned this thing of that this chapter the section we had written about exploitation is the cause of poverty, why people let it continue. Foucault describes it as a capillary process of power, operating at the lowest extremities of the social body in everyday social practices. So if it is not that we are sitting neutral, we are exploiting someone and somebody is exploited. So it's like a network of power and not just, from top to down. So it was quite interesting. And these were some of the people that who helped us during. And I would really want to thank Shiba and Jogi, because they made this book what it was, with this beautiful illustration. The Hindi translation was done by Sushil Joshi, and the title was given by Anupam Mishra of the Gandhi, late Anupam Mishra of the Gandhi Peace Foundation. So we asked this question when we were doing this book. Two things happened. One was the Bhopal disaster, and that is when I met Sheila, because she had come to our rented place in Delhi, and we both, sat and talked about, this huge devastation. This was in December, just as the devastation was taking place, and I had decided I'm not going to get involved. But through the MFC, I was asked to go, and now what I want to do is I want to talk about the my involvement in gas leak, the Bhopal gas disaster leak, which was purely emotional reaction to the huge amount of suffering that because I went reluctantly. At that time, MFC was doing one of the first survey, and it was only at the tail end of the survey I went and joined this survey, and then that is where I got hooked. So briefly, for people who may not be, completely aware of it, it's termed the biggest chemical disaster in the world. There are 40 tons of lethal mixture that escaped from a Union Carbide factory, which was actually a subsidiary to the American multinational. There was a runaway reaction due to water entering this thing. So where the methyl isocyanate was stored against all rules and regulation, so that's why these gases actually evaporate. They came out in a gush, and just outside the factory where all the poor slums. So people, they ran. They just took their children. They just left their children. They just ran, and there was instantaneous death. So in fact, the Hamidia Road, which was the road that was, the main road between the factory and the center of and the more the better part of the town, was actually littered with people dead or dying, and all the carcasses of animals. Official figures were 2,500 persons dead, but unofficial figures were more than 10,000 people dead. The cause of death, initially, immediately there was a big controversy. Was the death because of asphyxiation or anoxia, or were they direct toxic effects? Because these all had implications for compensation. So these are some of the images. I'm sorry, I should have given a trigger warning. And then these are some of the images of people dying dead. This particular thing is where it was just outside the forensics department of the Gandhi Medical College, where people had to come and identify. A lot of families died with nobody knowing, without any this thing. And so now I come to the controversy. So this was the death. So deaths could not be denied. I mean, because they were instantaneous. But one of the first questions that became a controversial was whether effects local or systematic, meaning systemic. Sorry, was it only because of the death was due to the inhalation of this thing, or did anything happen that did the gas really cross the lung blood barrier to cause other organ injuries to the other? The other question that was raised was, this is much later, I'm just compressing everything, the nature of exposure, because it was officially termed as one-time cecal inhalation. But it was really, it was very complex, because what was called inversion. So what happened was the gases came out, they went over the entire Bhopal, but because it was cold winter, it was the 2nd and 3rd December, they condensed, and then they inverted on themselves, and then they came back and they hung over Bhopal as a cloud for almost a whole day. So actually, it could not be seen as a gradient of exposure from the factory to the rest of the locality where populations were situated, but different areas were exposed to different mix of gases and in different concentration for varying periods of time. Why I'm emphasizing it is that this kind of a complexity was captured in only one study by an epidemiologist from the London School, Neil Anderson, who actually showed that, the clusters of symptoms were completely different. I must also remark that one of the first people to respond in terms of the medical situation was from MFC, and Dr. Abhay Bang is here. So Abhay was the one who went first to write about what was happening, what was the kind of medical, a tragedy that was unfolding in this situation immediately after the this. So this is one of the maps of, which show the gas affected. So according to this map, it was a concentration, this part of it is the dark part is the union carbide factory. Then it goes over the, old Bhopal, and the new Bhopal, it just comes. And then there were two big lakes. So now what happens is that the the gases get, neutralized because of the water. And then it goes to the more, leafy part of the town, meaning the more richer part of the town, but it was still a very dilute concentration. The people there were also definitely exposed. But what happened was that when the decision came to define who were the exposed, the immediate crude rates were used as to categorize as severely, moderately, and mildly exposed, following the gradient of distance, which was completely incorrect. So populations, that is, they were quite far away, who did not experience deaths in the immediate aftermath, were considered not exposed, which was not correct. They were exposed, but it was not, the exposure was not that great for it to be to lead to death immediately. At that time, the population in Bhopal was some 800,000, and strangely enough, there was no registration system, which is not likely to happen now with all the Aadhaar and everything. And they only, of which only 200,000 were considered exposed or affected because of this gradient. So the residential status became the criteria for claimant status, and not the exposure status. This is one of the very important critical thing that happened, that actually kept the compensation away from people who really required it. So this, not only that, what ICMR did was that they took a control population from the what was called the non-exposed, which was the other, the extreme part of the far away from the factory. And so when they did the studies, it actually diluted the assessment for gas effect, because the baseline was higher, because the baseline was actually of people who were mildly exposed, but they were being categorized as not exposed. There's one data that was from the government, one of the government authority, which showed where they mapped the vegetation, and they used neem tree as a marker, and they found that vegetation up to 25 kilometers, there was injury. So in fact, there was a documentary that was done by Ruth Waterman, who is also the one who made the statue or the sculpture outside the Union Carbide. She made a documentary called The Trees Cried Leaves. So instead of taking right from the beginning, the effort was to minimize the population that was exposed, and then we come to the fact of how they try to expose the number of injured. The other question was, what is a gas effect? So it was not like a factory accident where, one limb is gone. There is actually this was a chemical injury, and there was no specific marker. So since people inhale, it was an injury to the lung, the manifestation would be very similar to other kinds of clinical manifestation or other kinds of lung situations. But so this was another big question of what is a gas effect, which again had issues too for compensation. Should change in socioeconomic status also be considered as impact, or only the gas effect? Because immediately after that, people were so ill, and many people had lost their, the adults in their family, either the husband or the wife, that there was a sudden fall in the, even that little amount they were earning was. So there was added to the gas effect, there was also the effect of the socioeconomic impact. The question was again, what about pregnancy outcomes? Because there were a lot of women who were pregnant. And what of children who were exposed in utero and who were born out of it? And most importantly, what of latent effects? because this was bound to have a long-term effect, and how can we assess it at that point of time, which was immediately after the gas leak disaster. So now I look at three major studies that we conducted, which was, although they were in terms of sample wise and because of the limited resources were very small, they were very well thought out and critical and very important in furthering our understanding of what happened with the Bhopal disaster. The first study was conducted in March, within 3 months of the disaster, and this was because the activists who were working in Bhopal wanted the medical groups like MFC to come and do some study, because by the third month, people were still flooding the hospitals, but they were being sent away saying that they were malingering. And this was a new term was used as compensation neurosis, that because they want compensation, that they were actually pretending to be ill. But the very important thing was that among the medical community, there was a big debate about what was this pulmonary fibrosis theory and what was called the enlarged cyanogen pool theory. There was a controversy between that, because there were people who with multisystemic, organ, involvement, and they had symptoms, showing injury to several organs. So was this injury because of the lung injury, or did the injury because of uh, the gases have crossed the blood, lung blood barrier? This was very important for the compensation situation. So at that time, ICMR conducted a double-blind clinical trial using sodium thiosulfate, because Professor Sri Ramachari, he had theorized a very brilliant theory called this enlarged cyanogen pool theory. There, according to that, I don't want to go into it, that there was it was like something like a chronic cyanide poisoning, and sodium thiosulfate was the antidote, and they used sodium thiosulfate in the double-blind clinical trial, and they could actually see an improvement. But however, the victims were denied they were not allowed access to that, and that is another story which I don't want to get into it. And finally, the victims got access to it only through a Supreme Court order, after almost 1 year. By then, it was too late. So the study that was done by the MFC was a cross-sectional study which compared a population in a severely exposed with a non-exposed. This is what I said, the non-exposed, which was at the periphery of the Bhopal. And we used random sampling. And the study showed this two important findings. One is there was a simultaneous presence of serious symptoms involving not only lungs, but GI and central nervous system and the eye. But the more critical thing was there was exclusively non-pulmonary symptoms, where people did not have a pulmonary system, but they had other organ system. And one of the conclusion that we came to was that the population in the non-exposed also exhibited symptoms of suggestive effects, so they cannot be, or they should not be considered as controlled population. So this particular study established two things for the victims. One is that they were not malingering, because what was done was that it was a clinical examination and detailed history taking, like what anyone would do in a clinical setting, to show that they were really indeed they were suffering. And the second thing was that there were a certain subsection of population who were suffering even without lungs. So therefore, it supported the cyanogen pool theory. The second study that we did was on pregnancy outcomes. Now, this study was planned when we were doing the first study, because what happened was, again, the context. The context was there was suddenly the newspapers and other anecdotal evidence said that people were actually, the women were, there was an increased spontaneous abortion, but the newspaper said there's a huge amount of congenital malformation and very gory details and all that. So there was again a request by the activist group there that to the MFC, whether we could do a study on pregnancy outcomes to see what should be done, because the women who wanted abortion, wanted to terminate the pregnancy, were not allowed to terminate the pregnancy, and the ICMR was sitting on their they were not willing to make a commitment. So at that time, actually, Meera Sadgopal, Meera Shiva, and I, we went to the ICMR headquarters to talk to them. At that time, I think Dr. Ramalingaswamy was the person who's the director, and they said that because women ran during the disaster, that is why they started aborting, but not because of the gases. So we decided to do a study on a cross-sectional study. And for this, the faculty of the center was extremely helpful, particularly Dr. Imrana Khadir, and I think there was Dr. Nair, and also I think Mohan Rao was also involved, I think. And we decided we will not take a control from from Bhopal, but we'll take a historic control, that the women, the population that we would select through random sampling, they themselves would form their own control. So their history of spontaneous abortion and other things prior to that disaster would be compared to that. Now, we also included sorry. Oh God, where is it's gone somewhere? How do I go back?
The upward cursor you have.
Yeah, okay, right. Yeah. And so what we found was that there was a significant alteration in menstrual pattern, and there was an increase in spontaneous abortion rates in not only in the pregnancies that were there were already the women who were pregnant already during the gas leak, but because we did the study after 10 months, even in those who were conceived after the gas leak, there was a spontaneous abortion. And we theorized that the gas was probably mutagenic, because spontaneous abortions are a very great marker for environmental chemical injuries. But however, due to a set of unfortunate circumstances, this study could not be published for 5 years, and I don't want to get into why it was. I have already written about it. So this was a study, but the most important thing is, once we started talking about this, our findings, even before it was published, ICMR came out with their own study saying, yes, indeed, there has been an increase in spontaneous abortion rate in these women who were pregnant at the time of the disaster. But in the compensation, neither was spontaneous abortion, nor stillbirth, nor menstrual irregularities or impact on menstrual reproductive system was included as a cause of injury, even though it was debated. And so this part of the women's health was completely ignored in the compensation thing. So we come to the third important study, which was done in 1989, because by then there was a settlement that was announced in 1989 in February, and the settlement was announced without the assessment of how many people have been injured. So when the figures were produced in the Supreme Court, everybody was shocked, because only 19 people or somebody were considered or categorized as permanently injured or permanently disabled. So again, this was I highlighted Nishit Vora and K. Satish. So three of us, we decided to coordinate a study, and for this, again, the study design came from the faculty of the center, where we first did what the claim directorate had done was that they had created a personal injury evaluation process. This was based on individual assessment, because the Indian courts do not take epidemiological evidence as evidence. So we don't have tort cases, we don't have class suit action. Each individual has to prove that he or she has been injured, which is a problem with the medical legal part of this, again, which I will not go into it. So what they used in this study in this assessment was that they gave marks, like 1 mark if you had cough, 2 marks if you had sputum, 3 mark if you had chest pain, and then the person whose assessment was being done, he or she had to produce document to show he or she had actually gone to a doctor in the immediate after the disaster to say that this person had been to visit doctors. Now, supposing in the previous 5 years, lots of things had happened. So they had lost their documentation. They did not know the importance of it. So most of them did not have documentation. So these were people who were, so even if they had symptoms, they were considered not exposed because they did not have a documentation. So we thought about a way of overcoming it. So we actually accessed the pro forma of the surveys that were done in 1985, particularly the Nagrik Rahat Punarvas Committee, because for some reason we were not able to get other people's survey forms. And this became the documentation to show, because these studies were done in the immediate aftermath of the disaster. So these documents could prove that indeed they had documentation of injuries, which is very, well documented, because this was done, very sincerely by a group of people. And so first we made a theoretical critique of saying that in a clinical situation, nobody gives marks, nobody gives scores, nobody, uses a mathematical formula, detecting a certain mark or adding a certain mark to come to a conclusion. So the process to be followed is a clinical assessment, which is clear history taking, clinical examination, and investigation. We could not do any investigation because of resource constraint, but we had a group of doctors and other people. We had at that time about 40-45 people sitting in Bhopal doing this study. And it was again a random, again, we prior to doing that, we went through this great process of tracing these people who had gone, because 5 years had gone. So we traced the people. Once again, we got hold of these households that had been surveyed, and then we administered our survey form to say what happened in the third month of the disaster and what happened now. And we demonstrated that even if people did not have documentation, they were uh, mm, severely affected. Now, why this study becomes important is this study could be considered in an epidemiological sense, in a pure positivist sense, a bias study, because we went with an idea of showing that the assessment was wrong. But we could demonstrate by clinical, assessment that indeed it was wrong. So this is one issue that is always comes up, the bias in epidemiology, and which is actually the bias is celebrated in social sciences. And these two things are, in conflict all the time. And this I've seen in my PhD thesis as well. So what did we find? So we found that the personal injury evaluation adopted by the Director of Claims for categorization of injuries was designed to underestimate the nature of injuries, and by inadequately examining use of faulty tools based against the gas victims, they actually defined away the injuries of more than 90% of the victim as no injury or temporary injury. So this study becomes important because here there's a medical group, there's a medical professional group which is both, socially sensitive, and there's a combination of quantitative and qualitative data to show, to actually speak on behalf of the victim and use the same language as science to show that what is happening is incorrect. So these are some of the special mention. And in all this report, there are 2-3 pages of acknowledgement. So I didn't want to put it so people can read it, of all the people who helped us. So with this study, Nishit and I decided to intervene in the Supreme Court case with Indra Jaising as our lawyer. So how did we argue our case? So here I'm talking about use of technical, clinical information. How does it get used in a legal sense? So we argued that the personal injury evaluation should be on the basis of pathophysiological diagnosis and not on an arbitrary scoring system, as the Director of Claims was doing. Victims should not be asked to provide proof of the injuries. The onus of proof should remain with the state or with the group that has been the cause of the injury. the children who were conceived before and after the gas leak should also be considered claimants. The PTSD, post-traumatic stress disorder, is an event-related and not due to direct exposure. I just want to make a comment because the ICMR had done a mental health survey, but they refused to diagnose PTSD. And later, when I asked one of those people who were involved, I don't want to mention name, he said that that time that this particular diagnostic thing had not been was not available, which is not strictly true. The reason why PTSD was not diagnosed was it's event related. So you can be sitting in 50 kilometers from Bhopal and you can still have I mean, this is theoretically speaking, of course. So it is not direct gas exposure. So this is again to minimize the extent of injuries in the population. Women's menstrual effects and pregnancy outcomes, where we said we argued should be compensable injuries, and we argue for something called reopener clause, which I think was a brilliant thinking from Indra Jay Singh, which is right now it is only 5 years have gone. There's going to be latent effects. So even if the case is settled now, there should be a reopener clause. Supposing at a later time, new forms of injuries like cancer or anything else manifest, then the victim should have the right to reopen the case. Now, what happened was the Supreme Court case outcome, the faulty methodology of assessment was upheld. None of the other demands were accepted. But our study had a positive outcome. This was used to pay the victims in the ward according to the residential status interim relief. So everybody who were present, I mean, at least, on paper in that area, there's, I think, 26 wards or 36 wards, I don't remember exactly. They received an interim relief, monthly income for the next 2-3 years. And so when we argued for compensation, actually, I want to, this is one of the anecdote which is very, very important. We actually sat in the basti and there were all these women, because many of the death rate in men was much higher than that of women. So there was actually more women, proportionately in the. So we were sitting with these women and we said, what is your sense of justice? How would you like to be, compensated? So to which the women said, see, in Hindi, इसने भी गैस खाया उसने भी गैस खाया. Our neighbors also had, were exposed. We were also exposed. They had 2 deaths. We had 3 deaths. We had something. So how can you measure that? Just give us whatever it is on the same thing. We thought the sense of, individual justice versus a community justice was so far superior. And that is what, and our study actually supported it, because if 90% of the population that was exposed was injured, or we could show injury, then with this 10% getting the benefit of the doubt is better than getting the 90% to prove that they were injured. But it was not accepted. So the tragic, this is where I say that what has my life led to is, the tragic thing is the case for compensation still continues in the High Court, in Jabalpur High Court. And my colleague Jay Prakash goes to the High Court from Delhi almost every other week to argue the case. So no relief, the same compensation amount that was given by the Union Carbide was distributed. It's like taking one loaf of bread and distributing to everybody, and not the loaf of bread not increasing. So this is the biggest tragedy in our lives. So the whole Bhopal thing was based on population-based studies, all the 3 studies. But I wanted to compare it with the work that I had done on injectable contraceptives, where we did not do any population-based studies. This is almost all theoretical, almost all review of literature. So what is this? So it was against this injectable contraceptive, which is a 2-monthly contraceptive. It's synthetic progesterone, Netten. 1985, there was an incident in Hyderabad where women were invited to receive this, magic injection, and friends, feminists from the Sri Shakti Sangatana collective in Hyderabad and some of them also MFC members like Veena Shatrugna and Shama. They went to this particular PHC, and when they came to know that the women had not been informed that it was an experimental drug. So once the women heard that there were experimental drugs, and many of them had children, they were, postpartum, they all left. So the entire camp was for giving injection was disrupted. This was in 85. So then the Sri Shakti Sangatana decided to file a petition. So in 1986, petition was filed, which is a public interest litigation. And I was involved because I was sitting in Delhi at that time. So the petition was by three groups, autonomous groups. Autonomous groups here means non-funded collectives and with very loose structures, not registered necessarily. So Sri Shakti Sangatana, Saheli and Chingari, and some individuals. The respondents were Government of India, ICMR, Drugs Controller, State Government of Andhra Pradesh because it originated. But the WHO, who was the one that was actually involved in this trial from the back, because they were the ones who suggested that this, and the drug company which manufactured Netin were not involved. So the initial focus of the case was that unethical clinical trials without consent. And there was a bit on hazardous nature. But when we actually started looking at the chemical, the Netin injection, Netin contraceptive, we found that it was highly hazardous both to the woman and also to the progeny if she was pregnant or if she conceived later. So this formed the bulk of the thing. So what happened was once we filed the case in the Supreme Court under public interest litigation, the Drugs and Cosmetic Act, the drug controller inserted something called the Schedule Y, because till then, within the Drugs and Cosmetics Act, there was nothing on clinical trials. So actually, all clinical trials till then should have been considered illegal because there was nothing binding on them. In 1992, this was 1985, 1992, the US FDA approved the other injectable, Depo-Provera, which was a 3-monthly injectable contraceptive. And 1983, India approved both Netin and Depo-Provera for private marketing. They could allow for private marketing because and not into the public system, because our petition argued against the use of these injectables or the distribution of it through the National Family Planning Program. And since the case was still pending in the court, they could not do it. So it was at that time I did this technical review of epidemiological review of the injectable contraceptive Depo-Provera. And there was a reason for it because our case only covered Netin and it did not cover Depo-Provera. Depo-Provera would be considered a new and we cannot file another case. So this was a very technical case of establishing a technical case on scientific review of literature to say what is the harm a contraceptive like this can do. So this was the conclusion from the book. It appears to be hazardous to the health of the woman and her progeny. It appears to be not suitable for nulliparous women, adolescents, breastfeeding women, women who have not completed their family, and women who are in the reproductive age group. In short, there does not seem to be a single group of women for whom Depo-Provera can be safely recommended as a contraceptive method of choice. Now, why we took all this, why I did all this is this was the target group that was being. So as this was being published, two things happened. One was that they found association of Depo-Provera with osteoporosis. And the drug and all drug inserts had to have a black box warning. And the second thing that happened was studies started coming up which showed an association of this injectable, particularly Depo-Provera, with an increase in HIV transmission. And this particular monograph, which was published by MFC and Forums for Women's Health, and again it has got a long list of acknowledgement in the front cover, which I'm not putting. The only most important people who help I put here, actually was instrumental in strengthening the case in the Supreme Court, although no hearing had taken place. So using a technical tool to dismantle another technical But what has happened today? Situation today. Again, this is a where are we going kind of a thing. In August 2000, the petition was withdrawn voluntarily by the petitioner. I was not one of the petitioners, although I worked on the petition. The government of India gave written assurance in the court that injectable will not be used in facilities, in lower level facilities, only in medical college hospitals and I think district hospitals. But in 2016, under Mission Parivar Vikas, ICs were taken right to the sub-center, and ASHAs are advising women that and injectables are available at the PHC service, even in remote travel areas. So does it mean the harms have been reduced? Or does it mean that you're putting that this drug has been put into, because it's a very convenient contraceptive. So that is why it was being promoted, that, the husband need not know, you don't have to tell your mother-in-law, you don't have to take a pill every day. So this so-called convenience actually used the powerlessness of the women of a particular class to subjugate and subject them to another hazardous thing. And that is the situation today. The more important thing is the increased risk of HIV and transmission flagged in 2000. The Gates Foundation funded a study called the ECHO trial. This was called the Evidence of Contraceptive Options in HIV. It was conducted in 4 countries in sub-Saharan Africa. It was a 3-year randomized clinical trial, and it was basically designed to prove that this association does not exist, that there is no association. So if you're talking about bias, would one consider this study a bias? Because you set out to prove something and then you design a study. So then again, as a set of circumstances and luck would have it, I got involved. I was sitting in The Hague, and actually my blood was boiling with this study when I came to know about the study, and I was able to get the protocol of the study. And so this is very important. In any clinical trials, the protocol is absolutely critical. And although I was able to interview the top person who was conducting this trial, and without any, I never said a single lie. I told this person that I am so and so, I worked on thing. Only thing is they never did a Google search on me. So they treated me as someone who is just a innocent person who wants to do. So this person gave me all the information, but told me that I cannot quote a single sentence that he said. So I used the protocol and I did what is called a discourse analysis of the protocol. And I published a paper, Ethical Violations in the Randomized Trial. And what had happened was they had not informed the women who were part of the trial that they were actually testing this drug on them to see if there was an increase in transmission. And this is in countries in sub-Saharan Africa where the incidence and prevalence of HIV and AIDS is so high. It's one of the most risky population that it was being served to. Then there's the study when they published it in Lancet. They dismissed the study because even though it showed an increased transmission, because the p-value was 0.06, which is allegedly above the significant level, which any epidemiologist worth his or her grain of salt would say it is that maybe the power of the study was not large enough to detect a effect. It is because of that it was dismissed. And this study is published in Lancet, and I would really encourage all of you to, people who are interested, to look. Then I wrote a blog in our this thing because WHO is waiting for the results of the study to downgrade the grade of risk of injectable contraceptive from 3 to 4. So saying that it is not risky. So I wrote a blog saying why WHO should not do that. And this was picked up by BMJ, British Medical Journal. And I was commissioned to write an editorial, and which was published in this thing, and where I argued, the 0.06 p-value is being used as the thing. So it was like coming to a full thing. So the evidence exists that there is indeed an increased transmission. At least there is a very reasonable doubt, one should say, of increased transmission of HIV and STD, and not because of the injection. It's actually because of pathological changes in the vaginal mucosa, where if a man is infected, then the woman will get infected. If a woman is infected, she will shed the cell. So it's risk for both partners. So what happened? The WHO downgraded the risk and recommended the use of injectable even among risky population. Then another thing was, they said maybe they should be given prophylaxis in population who are at high risk. Give the injection, also give a prophylaxis. But the important thing, what happened in India, although I circulated this paper and in various forums that I'm part of, in women's group that are very, very active in the injectable contraceptive issue, as well as those groups that were working with HIV and AIDS, this thing, have been largely silent. And I don't want to speculate on the reasons. Now, this is the last part of my presentation, which is on the Global Polio Eradication Initiative, because I want to compare it with the injectable contraceptive, because both of them were theoretical. But whereas the injectable contraceptive campaign was a group of technical professional, like technically sound professional, joining with a group of the victim groups or people who the women's group, strengthened the struggle, and we could keep the Depo-Provera or the injectable contraceptive out of the family planning program for almost 10, 12, 15 years. Whereas in the Global Polio Eradication Initiative, although it was again a group of very high level experts who actually did the analysis, we were not able to do anything about it. So what was the difference? So WHO promised eradicating of polio by 2080 using OPV, oral polio vaccine. It is 2025 and we are still not eradicated polio. This eradication was worldwide polio. That was the promise. The 2080 was used as a mark because Rotary clubs, it was the centenary of Rotary Club, and they wanted to cover themselves with glory. Oh, what do I do?
Slides.
Yeah. So at that time, I was a visiting professor at the center. And a group of us, which is actually, that's what Rajiv was talking about. Dr. Rajiv Dasgupta, Ritupriya, Dr. Imrana Khadi, Dr. Banerjee, there's Dr. Deodar. We submitted a memorandum on pulse polio to the World Health Organization, UNICEF, and the Government of India in 2004 on the World Health Day. It was signed by faculty and several independent researchers. We said the polio eradication campaign has failed to achieve its goal. In fact, in 2002, there was a serious upsurge in the number of paralytic polio cases. And the cases has spread in 16 states. So this was from the memorandum. We are a group of public health professionals from India who wish to register a concern at the manner in which entire polio eradication initiative has been thrust upon our country. And this is what we demand. We demand an independent inquiry, a white paper on why this initiative was advised. Because what was happening was the entire child population was being inundated with oral polio vaccine. And we argued that given the epidemiology of polio, one could work on an elimination strategy and not an eradication strategy, and particularly not with oral polio vaccine. So this was a very highly technical argument that became the the foundation of this memorandum. This memorandum is available on the net. Please read it, those of you who are interested. So this is the paper we published in the International Journal of Health Services, Polio Eradication Initiative in India, Deconstructing the GPE. one of the tail anecdote, as it were, is I got a mail from Henderson, who is the smallpox person, and he tried to argue that our stand was, although he agreed with it, but he did not agree with it. But it was never followed up after that. So we ran this campaign using this technical information, which is actually could not be refuted. See, they could not refute the arguments. And that is the important thing. It's not like the counter argument was equally important. The counter argument was just a discourse. We have decided to do it, and we'll go ahead and do it. So I want to now conclude with some of the insights. I don't know how much time do I have? I don't have the on some insights and conclusions.
Another 10 minutes.
Yeah, I'll go quickly. So, given this work that I've done in this last, so many years, what I learn, or what I think can help, which I've written earlier also, that epidemiology can be a powerful tool in strengthening people's struggles. To design studies, a sound knowledge of clinical medicine is essential. We have Anurag and Madhvi here, and you all know the kind of work they've done. Abhay is here. Abhay and Rani have done similar kind of work. I don't know who else is here. I'm sure there are a lot of people who are doing this kind of work and strengthening people's struggles. And knowledge and power go together. Foucault. See, because I used Foucault, I learned about Foucault during my PhD, and it was completely important for my thesis. And so, hence, a particular discourse within a scientific community, which is knowledge, assumes not dominance, not because it is superior, but because of support from power structures. And that is the important thing. Whether we look at Bhopal, whether we look at the injectable contraceptive, whether we look at the GPEI, every case, every one of them had very sound alternative discourse created by us. That's a large group. When I say us, MFC, the women's group, Saheli, individual experts, everyone. And there was no counter discourse to counter our discourse. But the other discourse which we had, sort of dismantled, continued to be the dominant, because it gets support from the power structure, which is the state, the capital, or whatever. So to challenge power of truth claimed by these scientific bodies, which are also the epistemic authorities, what is absolutely essential is scientific rigor, which needs to be combined with people's power. And that is the difference between the injectable contraceptive campaign and the global polio eradication campaign. Both were very sound. The reason the global polio eradication never took off was within the alternate scientific community, that is our own group, there was a dissonance, because this horrible thing of anti-vaxxers. We were not anti-vaxxers. We were critiquing a particular vaccine strategy on the basis of epidemiological principles. So similarly, like for instance, in the COVID situation, the entire world, everybody went for the COVID vaccine, and it is one of the most untested vaccine that has been put in the history of the entire vaccine development. And today, life-threatening injuries are being reported, and they are collateral damage. So this thing of that, even within the alternate group, when there is no, agreement, that is one problem. We could not take the global polio eradication initiative argument to the people who are actually the parents of the children who are using it. How can you translate it? So this debate remained in the academic world, in the scientific world, in the political world. And that is why it could never, get any purchase. This is a larger thing which I have seen, that both in the Bhopal gas leak and injectable contraceptive, because this sort of straddled our political spectrum, as it were. We started in the 1980s, where a different government was in the center, and we are ending now, when there is a different center. So instead of looking at it as a political party, one needs to look at as the nature of the Indian state, and it has not changed. I mean, it's the same anti-people, anti-caste, anti-women, anti-whatever, and pro-capitalist. And this is very important to understand. 19-20 farak. The more important thing, another important thing is the state has a long-staying power. And it can afford to retreat a little, like the way they did it with the Netton case. They could stay back, make small concession. Yes, we will sign a letter saying that we will not use it. And by their time, because by then the groups, the women's group and other people's movement and all that has sort of frittered away the energy, or they got tired. So when one is sort of confronting the state, this is something that one has to understand, that retreat by the state does not mean victory for us. It's a very small victory. The important thing, this is where the hope comes, that every single strike against inequality and injustice is important, whether it's small, whether it is big, whether it is Bhopal, whether it is the domestic violence within one's own household. But these have to merge to bring about lasting change. So there's a micro politics of everyday struggle, and there's a macro politics of global economic and political processes. So this is where our new study on digitalization and food assistance comes, because we are looking at 3 countries, Sudan, India, and the UK, where we are saying we should no longer look at global South, global North. We should look at in terms of class. The poor in the UK are as badly off as the poor in Sudan, in different ways. So this is a very, we go into a different paradigm altogether. So this is something I always tell my students when we talk about it, that, although Stephen Covey's book, I'm not very, greatly taken, but this thing of cycle of influence and cycle of concern, we may have a cycle of concern, terrible things are happening to the climate change, but maybe we're not able to do anything about it. But we have a circle of influence, using our knowledge, using our skills, using our strength, and we work on that so that we don't lose hope. So I wanted to, this last 3 slides. This is one of my, the poet. She's a Somalian, but she's a British. She says, later that night, I held an atlas in my lap, ran my fingers across the whole world, and whispered, where does it hurt? It answered, everywhere, everywhere, everywhere. And that is the situation we are in. We are hurting, the entire world is hurting. But I want to leave with a positive note, the challenge and the hope. This is again something, I tell my students. This is when I was living in Delhi. I used to live in Sukhdev Vihar, and that time there was a flyover was being constructed from Sukhdev Vihar to Lotus Temple. And beneath the flyover, this is not my photograph, it's not original. All the construction workers would be sitting in utter poverty. The construction workers are one of the most destitute people among the laboring force. Yet, as one went over the flyover, one sometimes saw these dramatic skies because of monsoon. So the challenge for me is, we are sensitive to what is happening, but we also should take time to look at the beauties of the world. And to me, what happened with the farmers, struggle when they sat outside in the cold during the COVID, so many people dying, is a huge, ray of hope. And it was one of the most important protests in the entire world. But it was never picked up by the international media or even the Indian media. And this is a labor activist who was killed in jail, and his thing was don't mourn, but organize. So what does Foucault say? The work of an intellectual is not to form the political will of others, but to take part in the formation of a political will, using his or her role I mean, her strengths. And Gramsci says, pessimism of the intellect, optimism of the will. I'm a pessimist because of intelligence, but an optimist because of will. This was a letter he wrote from the prison. So, on a positive note, one of my biggest achievements, which I think, which I've seen in my lifetime, is the Jansarthya Sahyog campus in Ganyari. This was the campus when we went in 1999, 1998. Broken down buildings, a savanna kind of a grass, golden, beautiful. It had its own beauty. 1.5 trees or something with lots of dimak. So we planted trees. That is Vinayak, I, and other people from the center. Today, it has become an ecological niche. Many of the trees, I feel very proud, planted by me, 25 years now, 25 feet high. Now they attract birds, they attract all sorts of living organisms. They are allowed to live because it's a rural hospital. So there are bandars, there are dogs, there are everything, and there are also people. So this is my final slide. This is a poem I wrote. Bombed out crater, a flower blooms in defiance. And this is a photograph during the Vietnam War protest in 1967, where this young girl, 17-year-old, she held a flower in front of the soldiers with guns and bayonets. And it became an iconic. But today, when so much of suffering is happening, there is war, this is not allowed to happen in their country or in any other country. But there is still hope because the flower will bloom. So thank you so much for this opportunity.
Thank you, Satya. And I won't dare to summarize. I invite Professor Sheila Zurbrigg to give her closing remarks. I think you're muted. Yeah.
Yeah. Well, I shouldn't be the one speaking. I'm aside from being speechless. I'm overwhelmed, Satya, by your life and work. I would have been overwhelmed from the first 2 steps that you've taken in the last 40 years. I think your message is extraordinarily important for all the reasons you've conveyed. But also, as we go through into the future and the struggles we're facing. The personal struggles here where I'm sitting in Canada is preoccupying for many of the public, for many Canadians, in terms of just bare survival versus against the Trump administration and this disintegration of public care and sanity in the US beside us. It's affecting us profoundly economically, and we have challenges just in our own daily lives here because of that. But of course, we have far greater challenges particularly in relation to the urgency of the planet and climate change. So I'm delighted that your work has continued, and that you see the lessons and strengths of your commitment to issues in India as a resource, in a sense, for the additional challenges that we're immediately facing in terms of climate. I have to say that just personally, the experience in the 1970s, there was mild, relatively speaking, mild drought and harvest failure in southern Tamil Nadu in 75, 76. And the effect of the rains failing were so obvious, so devastatingly obvious, even then. Children being sent out, 6-year-old children being sent out to the match factories because there was no other work. There was no other livelihood for families. That it has stayed with me. The climate issue has been with me for years, the implications. So, what can I say? A recent report just in the last year assessing the effects of increased heat temperatures and drought in India in 2024, last year, suggests, they say shows, that the effect of temperature is far, far greater even than the effect of drought, of rainfall on crop output. And I guess I hadn't been thinking in terms of that. I was thinking of rainfall, but so the urgency is so real. I suppose the real too, but it's so real. And I'm thinking that your experience is so important in terms of bringing the voices and the experiences of those affected, and of course the poor and powerless, to bear on how all of our societies, including India, addresses these effects that are coming with climate change. And I'm sure there are sensible solutions, and that's, of course, transitioning off fossil fuels. And how that is seen and achieved at village level is an equity issue, profoundly, and needs to be shaped and controlled by those most affected. And how is that going to happen? Well, we know Meena and Raku and all the other women who know precarity, know what needs to be done, and we all need to be listening and supporting them and working together. And I just am very glad that your experience and the way you with the way you are communicating it to so many people, about beginning at village and the level of the poor, is where we need to be in this struggle. And over the final years that we have, it's going to be very important to remember your words and their words in how we act and respond. That's all. That I want to pass this over to everyone else quickly for more input. But thank you. Thank you to all of the alumni of the Center for Social Medicine and Community Health and Medical Friends Circle. So we're in this together.
Yeah. Thank you.
Thank you, Professor Zurbrigg, for your closing remarks. And what more I can say, it's been a real learning experience connecting the various dots in your 40 years of life, both local and also international. Local also takes back us to the different historical points, what has been going on in our country and what we need to stand up for. With this, and we are also going through very difficult time here. And with this, I like to ask all the webinar people here who have joined us to open their videos so that we can all have a group photo, which will be followed by a vote of thanks by Professor Ramila Bisht. Yeah. Thank you, everyone. Over to you, Professor Bisht.
I'm deeply honored to propose this vote of thanks. And on behalf of everyone present, I wish to thank firstly Dr. Sathyamala for for an excellent, truly inspiring address, for showing us your life work with so much of clarity and so much of passion, for showing us the possibilities and the challenges, the power of academic and activist intersections, and for making it possible for young people today to still dream for the future, of the possibilities, to face the challenges but still be able to work. And for the public health as a whole and for the people's struggle. So thank you so much for it. And Chair Professor Zurbrigg, thank you for your brilliant remark, for drawing and connecting it to such different contexts and talking to us about things that are happening in your part of the world. Very, very valuable to us. What a treat on one evening to have both of you. It's really been a big treat for us. Thank you so much. Then I would like to extend a vote of thanks to all those who made this possible for us. And particularly this goes to the working group members of the People's Health Oration. They are the Alumni Association members, particularly Professor Ritupriya, Bijoya, Shaveta, Neetu, Sukanya, Mahesh. and Prachin, who represented the CSMCH faculty in this working group, and Manmohan, who represented the students and worked with the team to put this event together. Sukanya made this beautiful poster for us, and Manmohan and Mahesh did the difficult task of sending out, I think, thousands of emails. So thank you to both of them. Aryan, Asararul, and Shaveta have been the technical team, and they've been working very hard to make this program go smoothly. Zoom room provisioning was provided by Dr. Sunita Reddy. Thank you to her for this. And I would also like to thank our chair, Dr. Rajiv Dasgupta, and all the faculty members who supported in organizing this event. Last but not the least, on behalf of the entire team, thank you to all the wonderful participants who spared their time to attend this, both here on the Zoom as well as those who've been listening to this on the YouTube. Thank you so much. Thank you on behalf of everyone.
Thank you, all of you here. We'll now keep the chat open. If anyone has to share any questions or comments, please share it here. And you can also leave your email.